Sir, shall we wait for 2 minutes, sir?
No problem.
Thank you.
Are you guys ready?
Hello, sir. Good afternoon, sir.
Hi, madam. Who's this?
Sir, I'm Saloni, sir.
Saloni. Okay, I don't see you. Okay, you're there. Okay, fine, 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 fine. Um, Go ahead, Saloni. Is this a real case or what to say, virtual case?
Sir, it's a virtual case.
Have you seen one case of melanoma?
Uh, no, sir.
Okay, fine. See, I will be happy to listen to you, and if there are any difficulties, I will be happy if other students can step in to help Saloni. All right. So you go ahead with the presentation, Saloni. One
Okay,
second,
sir.
1 second. Yeah, start, Saloni. Good afternoon.
Yeah, good afternoon, sir. A 32-year-old patient, Mr. Ram, a vegetable vendor by occupation, came from Kundratur, belonging to a low socioeconomic status, came with chief complaints of pigmented lesion in the inner aspect of the right foot for the past 2 months. History of presenting illness. The patient was apparently normal 2 months back, after which he noticed that a mole in the inner aspect of the right foot, which was initially smaller in size, progressed suddenly and attained the current size with a change in color from brown to black, and it was associated with itching. The patient,
Saloni, I will be happy if you can quantify the location in a better way. See, inner aspect of the right foot is fine for a non-medical person, right? So
okay,
either you should go with some bony landmarks or with toes or medial arch, lateral arch, heel,
sir,
ball of toe. Those things have to be told because in exam, inner aspect of the right foot is, I would say, we could locate as a broader way, but if you can anatomically reasonably localize, it will be easy for us.
okay, sir.
Can
So
you
the
rephrase your statement?
okay, sir. The patient was apparently normal 2 months
No,
back,
those are all
after
fine.
which
You are fine those aspects. Where exactly is the lesion? The location alone you rephrase.
sir, it was present below the medial malleolus, sir.
That is more easier, no, rather than having an inner aspect of right foot is too complex for anyone to understand because in most of the students may not have figured out what you're trying to tell or where it is. So you tell it is
Okay,
in
sir.
the below the medial malleolus or behind the medial malleolus or in front of medial malleolus. And then when you mention about near the medial malleolus, you tell how many centimeters or millimeters away from the medial malleolus. That will be a very
Okay, sir.
simpler format. Go ahead.
Okay, sir. He has a history of a long-standing exposure to sun. There is no history of ulceration of the lesion. There is no history of bleeding, discharge, or crusting from the lesion. There is no history of pain associated with the lesion. There is no history of nodules or lesions in the surrounding area, and there is no history of new moles elsewhere in the body. There is no history of trauma to rule out traumatic cause.
And
And
1 second, can you go back, Saloni?
yes, sir.
See, when you talk about new mole elsewhere in the body, you should also add up whether the patient has a mole at all primarily, apart from this lesion. We are interested in knowing about it. And then if there are any existing moles, is there any change in the existing moles? And then comes the occurrence of new mole. All
Okay,
right.
sir.
So
Yes,
patient
sir.
does not have any documented mole or patient does not give any history of existing mole in apart from this lesion anywhere in the body. Then comes the no new occurrence of mole anywhere in the body. That should be the right approach. Go ahead.
Okay, sir. There's no history of loss of weight and loss of appetite. There's no history of passage of dark colored urine.
What do you think is
No,
the importance of dark colored urine?
sir, we are asking this history to rule out melanuria if there is any discharge of melanin pigment in the urine, which occurs in the
Are you
late stages when there is a metastasis. So these history I'm asking with
you
respect to metastasis.
okay? For a 2 centimeter lesion or from the history, you have any you want as a relevant negative history, it's fine. But I would say this will be mostly a short case for you, right? So
Okay.
limit to relevant things. Now for the class, it is okay. But when you're, they may ask you to write a brief positive and negative findings. So stick on, if the patient is suspected to have metastatic, then you tell this. Otherwise, you limit to the lesion as such. Okay, go
Okay,
ahead.
sir.
Go ahead. Go ahead. Now you've run through the presentation. Being a class, it can be exhaustive. Go ahead.
Okay, sir.
Hmm.
There's no history of visual disturbances, no history of jaundice, abdominal pain, and abdominal distension, no history of cough with hemoptysis, no history of chest pain, no history of bone pain, no history of headache, seizures, blurring of vision, and projectile vomiting. Past history. The patient has no history of similar complaints in the past. Patient is not a known case of diabetes,
Go
hypertension,
ahead.
TB,
Go ahead.
asthma. Personal
Go
history,
ahead.
patient. Okay, sir.
Hmm.
Family history, the patient has no history of any similar complaints in other family members. There is no history of occurrence of multiple moles or any other skin cancers in the patient in the other family members of the patient.
Hmm.
Summary: a 32-year-old male patient presented with complaints of pigmentation below the medial malleolus of the right foot for the past 2 months, which progressed suddenly, and it is associated with a change in color of the lesion from brown to black and also with itching.
Then along with it, no, wait. Along with it, you also should tell patient does not give history suggestive of regional or first local, regional or distal spread
Metastasis.
or
Okay.
metastasis or spread, whatever word you use. So
Okay.
that completes your thing. And also you should tell, is there any associated history-wise associated complications? What are the potential complications of melanoma, you know?
Uh, so bleeding and
Yes. First thing
ulceration.
is ulceration. Second thing is bleeding. Then what are the
Uh,
complications of metastatic melanomas? Where all
uh,
metastasis can happen?
so it can happen in the lungs, liver,
Okay.
bones, brain, and to the
Okay.
lymph nodes.
We will
Mostly
come to the
first,
staging. See, whenever you answer, you go from local regional, and then go for the systemic things. So when
okay,
we tell how it spreads or how it is metastasis, I think so. Generally, up till the regional lymph nodes, it is coming under N category. If it
yes,
is
sir.
beyond, say, assuming in your patient, you have what are the regional lymph nodes, potential regional lymph nodes in your patient? You said it is just along the medial malleolus.
Yes,
So,
sir.
what is the first basin of drainage?
So into the inguinal lymph nodes.
First thing is popliteal group of nodes. Generally, popliteal nodes are not that very fixed. So, you may or may not establish a popliteal node, but then you should be first checking for a popliteal node. But the
Okay,
most common junction box for the leg is inguinal.
inguinal.
So, what are the groups of inguinal lymph nodes? You know,
So there's a superficial group and a deep
okay.
group. Within the
Then,
superficial group,
hmm,
it is arranged in the form of T. Uh,
okay.
Below the inguinal ligament, there is a horizontal group,
Hmm,
which is divided into a supromedial and a supralateral part, and there
hmm,
is a lower vertical group.
hmm.
And mainly from the lower limb, the lymphatic drainage will be going into the vertical group of lymph nodes.
Perfect, perfect, excellent. So, if somebody is going to ask you, so you have to tell the first nodal junction or nodal deposit can happen in the vertical chain of the infrainguinal group of nodes. So that should be the right thing. Then you did a good classification. Go ahead. So if there is a disease from in your patient, from the foot, if it is within the infrainguinal region, it becomes nodal disease. Assuming it goes to the para-aortic or internal iliac group of nodes or obturator group of nodes, what happens?
It's a distant metastasis.
Distal nodal metastasis. Then what are the distal parenchymal? Where all distal parenchymal metastasis can go?
So the lung, liver, brain.
So the first station, common station, depends on what type of melanoma are you dealing with. But then generally it can be into non-contiguous nodes to the liver, to the lung, and very advanced. See, principally metastasis is classified as nodal metastasis, pulmonary metastasis, and non-pulmonary metastasis. Do you know the M assessment? What are the different types of M one could read in a TNM classification in melanoma?
So the TNM staging, so the MX.
M alone, you tell about the M alone.
The MX, when the metastasis, it cannot be assessed.
Cannot be assessed or it has been operatively removed.
Okay, sir.
Okay,
And
right.
M0 means no metastasis, no distant metastasis.
Okay.
M1, it is divided into like M1A,
Very good.
where it will be going to the skin and the subcutaneous soft tissues. And M1B will be to the distant metastasis to the lungs. And M1C,
M1A, what you're telling is correct?
sir, to the skin and the subcutaneous soft tissues.
Okay, go ahead. You run through, then we will discuss again. First you finish the first you tell this M1, M1A, what is M1B and C?
So I should say again, sir.
B and C you say.
So B will be to the distant metastasis to the lungs, sir, with or without M1A, and
Okay.
M1C will be to the CNS, not to the CNS.
Okay.
And M1D will be
Non-pulmonary. That should be a right approach. Okay, go ahead. That's fine. You're doing good. So now having said that, from your history wise, whatever so far you told, what could be the potential clinical stage or clinical staging what we are dealing with?
So for the nodes, like there is
From the T point of view?
From the T point of view, sir, but that T will be giving with respect to the thickness, no, sir, like the thickness.
Clinically, then you say clinical T staging is indeterminate. All right. So now you go to the N status.
With the history, it's N0, sir, because there is the patient does not.
But the history alone we will limit to that. Then we will go to the clinical finding later. Okay. So whatever we are dealing with looks like a possible very early lesion. What we are dealing with. All right.
Okay, sir.
So now you said there are some risk factors in your history which you mentioned. What are the potential risk factors we are talking about?
So first, so the history of prolonged exposure to sunlight.
Okay. What are the types of sun exposure classification you know about melanoma?
So exposure to ultraviolet A and B waves, sir.
No, first thing is when you have subclassification of melanoma, they generally are not as per your standards, but you should be aware there is a subclassification which is based like say based on sun, that is the chronic sun dependent melanoma and non-chronic sun dependent melanoma. Okay. What are the principal pathological change which happens prior to melanoma, or which is the risk factor for converting a sun exposure to melanoma?
So like there can be a very prolonged exposure to sun, which will have a cumulative effect, and it will lead to mostly it is the pathological basis in the lentigo maligna melanoma types, where a long prolonged exposure to sun it will lead to like initially there is a precancerous lesion, lentigo maligna, which is an in situ carcinoma. But because of the prolonged exposure to sun over many years, it will become into a invasive carcinoma, which is lentigo maligna melanoma, and so it will have a very late onset in the disease process.
Can
And
you
other
tell, go ahead, you first finish, let me ask. What is the progress of sun exposure to melanoma? See, there should be some progress, right? There should be some pathology which is changing prior to it. I understand how or what pathology you are trying to tell is very well understood. How do you categorize that? That there should be some change in the skin or change in the melanocytes. What really happens because
so
of sun exposure? You say UV exposure, that is the basis of sun change. But then even people who are never exposed to sun also get dry. So there should be some changes, pathological changes, which happens because of sun exposure. What exactly happens?
the dysplastic changes will be happening.
Prior to that, dysplasia is almost pre-malignant, right?
Yes, sir.
So what happens is, it is called solar elastosis.
Okay, sir.
Okay, it is called solar elastosis. That's what really happens before getting into dysplastic states. All right,
Okay.
so you should be prepared. One is chronic sun-dependent melanoma or chronic non-sun-dependent melanoma. And then some specific skin types are more prone for melanoma?
Yes, sir. Red-haired, fair-skinned people, they are more
Okay,
prone for melanoma, sir.
okay,
And then the patients who have albinism
correct.
and
People who are in the polar region or who are exposed for more higher UV exposures.
yes, sir. Okay.
Okay, right, good. So having said that, in your patient, except for this sun exposure, you don't seem to have any other risk factors. All
Yes,
right.
sir.
So what are the familial risk factor? What are the types of familial risk factor you will be keen in knowing about?
So familial risk factors. The first thing, familial dysplastic nevus syndrome,
Okay. What are the
where
components of dysplastic nevus syndrome?
so in dysplastic nevus, the patient and many other family members will be having multiple moles. So it is also called as
Very good.
familial atypical multiple mole melanoma syndrome.
Very good. Very good. Good.
And
Nice.
sometimes we'll be having like more than 100 nevus will be there in this
Very good.
patient.
Very good. Very good. So then that is
Uh,
one important thing. Then
and and they'll be having a 100 like 100%
we move 100% what?
risk of
Okay.
becoming into a
So they have a
melanoma.
definite risk. So by the
Yes.
time what is the most common age of melanoma? Which age they are more, when do they present with melanoma? These type of
So,
risk factor patients.
so in this familial syndrome, sir, or
Yes.
generally?
First you tell general and then go to the family.
So generally, it will be coming more in the young adults between 20 to 40
Okay.
years of age. And if
Okay.
it is associated with familial syndromes, they present at an earlier age
Okay.
because they already
So,
have the risk factor.
okay. So one thing you should be aware, when there are like lymphoma, these people also have bimodal presentation. Usually, as you rightly said, in the second or third decade is one presentation. The other ones are at the sixth decade. The next common age group is the sixth decade. But then the age group, what you mentioned, relatively present in the early stages. But when they present in the later age group, sixth decade or seventh decade, generally they are fairly coming with an advanced stage. All right. So you should be
Okay.
aware there are a bimodal spectrum. 70 or 65% of the patients do present with the common age of what you said. Then the remaining present beyond 60. All right. That is number one. Number two, which sex has more predilection for melanoma?
Uh, so for different variants, like there
Tell
are different.
who have more higher possibility?
So in the nodular type, the males have a higher propensity, sir.
Okay.
And And in the next one, let us see. The lentigo
Yes.
melanoma type will be having female predisposition, sir.
Very good, very good. Excellent. So that much you know it's fine. Then we move on. See, we were talking about the familial risk factors. So if you ask about apart from the familial risk factors, what are the other potential risk factor? We discuss everything. If you can sum up, we discuss in separate formats. But for the exam reason, if somebody is going to ask you one single question, please list out the risk factors for melanoma. What are you will tell?
The
We
first,
discuss patchy here and there, we discuss separately, but you put together, you summarize.
okay, sir. The first we'll say about the ethnicity, white-skinned people.
Fantastic. Yes.
Second, we'll say with respect to the ultraviolet radiation
Very
exposure.
good.
The third we'll say about the familial cancer syndromes,
Okay.
and
Okay.
also the genetic cancer syndromes like xeroderma
Very
pigmentosa.
good.
And then we'll say about the pre-existing pigmented nevus like junctional
Fantastic.
nevus, compound nevus,
Fantastic.
Hutchinson's lentigo or lentigo maligna.
Very good.
And then we'll say about the history if the patient has a history of previous melanoma or a history
Fantastic.
of previous skin cancer, or if
Mhm.
the patient's family member or a first degree relative has a history of malignant
Positive
melanoma.
melanoma. Fantastic. So these are the cumulative risk factors. Right. So having said this, you move ahead with the presentation. Now we move on to the clinical finding. Then we come back to a little bit about the molecular pathogenesis. Go ahead.
Okay. General examination, after getting consent from the patient was examined. The patient is
See, when
conscious.
you're talking about consent, you tell in one go. It's not you take a general examination consent and a local examination consent. After taking a well-explained consent, if you are dealing with a lady patient or a male patient, with the chaperone or with an attendant, patient was examined. There it's the point, right? So
Okay.
you don't need to tell general examination separate consent and local examination separate consent. Go ahead.
Okay.
You are fine. Go ahead.
Uh,
So you don't have any positive findings in the general examination. Go to the local examination.
okay. Uh, then I
Go back, go
examined.
back, go back. What is occult melanoma?
The occult means when there is when the primary is not visible or it is unknown. In those cases,
No, occult is most of the time it is not seen to our eyes.
yes, sir.
Other the right word is obscure melanomas. Obscure is hidden,
Okay, sir.
right? So you tell we would like to locate or we like to look for potential other uncommon locations of melanoma.
Okay.
Generally, you will not be having time to do this, but you tell, I examined the possible mucosal areas and the nail beds where I could not find any other focal melanomas. That will be a limited safe word.
Okay,
What
sir.
are the other non-conventional areas? You mentioned about the scalp, nail bed, tongue, external auditory canal. What are the other areas you can have melanomas?
So it can be present. It can come in any area where there is melanin, like in the choroid of the eye and in
Okay.
the leptomeninges.
Uvea and choroid. Then
Uh,
what
then
comprises leptomeninges?
so the pia and the arachnoid matter.
So the secretory part of the brain. So
Okay.
secretory part where all you have the CSF secretory areas, they're all possibility of melanoma.
Uh, then in certain mucous membrane areas
So
like
GI tract where all melanomas are common.
uh,
Common thing is anorectal melanoma. All right.
okay.
Then when you go up, then comes the esophageal melanomas. The first common is anorectal, next is esophageal, then remaining melanomas are unusual, but they can occur. So then you come down in genitals, you can have from mucosal melanomas like that you tell. When you do a oral examination, you can have any mucosal membrane melanomas. And in women, the genital melanomas are also is a potential possibility. All right. So
Yes.
you categorize into one is non-specific locations are uncommon locations, which are very categorically mentioned. The ungual, oral, or external auditory canal, or orbital, all those things come under. Then comes under where GI tract. Most of the time, GI tract is an incidental diagnosis, or when they have diagnosed itself, it is metastatic. So it's very difficult to ask or find out through, unless you do a rectal examination or do a proctoscopic examination, you may be able to see. And or otherwise, if the patient says, I've been diagnosed already, it's very difficult to say on clinical examination. As well, even in uveal melanoma or any other orbital melanomas also, unless patient has a very advanced disease, it is very difficult to clinically examine to say. Is there possibility to examine the eyeball for
No, sir.
melanoma as such?
No,
It's
sir.
usually a specific examination with the help of other devices rather than a naked eye examination.
Yes, sir.
Okay, so these things can be better avoided unless the examiner, see, the point is in exam, the more relevant answers or relevant positive answers or negative answers you give will get you scores. These are areas which are little uncommon. You tell in single line, sir, I look for non-conventional areas to locate if there are any other associated focal melanomas. I could not find any. If the examiner asks you, then you can tell this.
Okay,
All right, go ahead, go ahead. But fine, you have listed out well. You list out in non-conventional organs, mucosal organs. That should be the right approach.
Okay, sir.
Go ahead. This is fine. Go ahead.
Next slide. Local
Fine.
examination. Examination of the right foot. Inspection. A solitary black pigmented plaque of size 4 cross 3 centimeter, irregular in shape, with an irregular surface and an ill-defined border, with a brown halo around the lesion was seen, and the extent of the lesion.
Can you tell what is a haloma?
So halo will be an area of depigmentation around the lesion.
Okay, good. Go ahead.
Extent of the lesion, it was 1 centimeter below the medial malleolus.
Very good.
The upper border was 1 centimeter below the medial malleolus. Lower border 5 centimeters below the medial malleolus. Anterior border 8 centimeters from the posterior end of the foot. And
That's very difficult to tell, but you need not worry if you tell this. The first two things it should be fine. What is posterior end of foot? Or you mentioned from the heel. It's very difficult. If you tell two things, it is fine and good.
okay, sir.
If you want to tell, you can tell about the dorsal and plantar junction, the mucocutaneous, like the dermal junction, the pigmented and non-pigmented plantar aspect junction. But those things are very variable. The first line is sufficient.
Okay, sir.
Go ahead.
The skin over the lesion is black. There is no ulceration, fungation, or crusting over the lesion. There is no bleeding or discharge. There is no scars, sinuses, dilated veins, or visible pulsations. There is no satellite or in transit nodules seen around the lesion. There is no visible lymph nodes, and there is no other similar lesions elsewhere in the body. Then palpation, the lesion, it is not warm, it is not tender. The inspectory findings of the site, the size, shape, extent were confirmed, and it is firm in consistency with an irregular surface. So it's a typing mistake. Ill-defined borders.
No worries, no worries.
Ill-defined borders, and the surrounding area is not indurated. Examination of the regional lymph nodes for the inguinal nodes. On the right inguinal region, a single lymph node of size 1 cross 2 centimeter, it is palpated in the right inguinal region, which is non-tender, hard in consistency. It is mobile, the surface is smooth, and the skin is pinchable, and it is belonging to the lower vertical group of superficial inguinal lymph nodes. And on the left side of inguinal region, the lymph nodes are not palpable, and no other lymph nodes are palpable.
Go ahead. Next slide.
Diagnosis. malignant melanoma of the right foot with no satellite nodules or in-transit nodules, and with a right-sided lower vertical inguinal lymph node enlargement without any complications.
What is the clinical stage?
So, the T, it is indeterminable.
Okay, T is indeterminate because you don't
Uh,
know the thickness of the lesion, but it
uh,
looks like more than 1 millimeter the way you say, right?
okay, sir. So then,
Okay, fine. You can tell T indeterminate, no worries. Then what is the end status?
N status, it if because there's one clinically detected lymph node, so it will be N1B,
Okay.
and M, it is XMX.
Okay. M could not be assessed or
Determined.
M clinical M is 0. That is all you are
Clinical.
expected to tell.
Okay, sir.
Okay. So now we move on to a little bit about the biology of the tumor. So what are the typical mutations of melanoma?
So there can be BRAF mutations and
The
the
graph, yes, very good,
in the MAP kinase pathway
very
mutations,
good,
mitogen
very good,
activation protein kinase pathway,
very good. MAPK, right?
and usually with BRAF there is a BRAF V600E mutation,
Very good.
and
What are the other uncommon mutations? BRAF is the one which helps you to decide about the immunotherapy, even if you are immunotherapy or monoclonal antibody therapy to be decided upon. Then what are the other things? What are the other mutations? Uncommon mutations, but it is important for an MCQ point of view.
uh,
The
so
KIT mutations and the NRAS mutations are the next important thing from your MCQ point of view. For your exam point of view, you can limit to only BRAF. People are going to agree with that. Okay, right.
okay.
Then you told about the T staging very well. Fantastic. How do you do stage grouping of this TNM?
So with the TNM, sir, like T,
Correct. Hmm.
so for the
You
stage
tell
one,
like this. What? How do you tell stage 1, stage 2, stage 3, and stage 4? That is always fine. That becomes life easier for you.
so stage one, it will be like with T1A, T1B, N0, N0. Stage
Correct.
1B will be T2A,
Mm-hmm.
N0, N0.
Okay.
Stage 2A will be T2B, T3A, N0, N0.
Okay.
Stage 2B will be T3B,
Mm-hmm.
T4A, N0, N0.
Okay. So,
Stage
okay, I will make life easier for everyone who's listening to you. They'll get bored and they'll get lost. What are the clinical staging? If you are asked to say you clinically stage 1 to stage 3 and stage 4. Can you clinically tell in one line about stage 1, 2, 3, 4?
okay, so 1, 2, 3, 4. Yes, sir.
Hmm. Hmm.
So 1, 2, 3, 4. In 1, we are dividing into A, B. 2,
Mm-hmm.
we are dividing into A, B, C. 3,
Okay.
also we are dividing into A, B, C. And stage
Okay.
4.
Okay.
When there is distant metastasis, that will straight away come to stage 4.
Okay.
Whether
We
it is
will forget about stage 4. What is stage 3?
stage 3, when there is no involvement of the nodes, then it
Mm-hmm.
will come in stage 3, sir.
Mm-hmm.
Uh, like till stage 2, the n will be 0. Once any
Okay.
node is detected, then it will come in stage 3, and then we'll further classify it based on 3A, 3B, 3C.
Okay.
Like
So can
if
you
it
tell
is
about little bit about the N status once again? What is N1? What is N2? What is N3?
N1, it is further divided into A, B, C.
Okay.
N1A, a single node detected,
Mm-hmm.
which could be occult. In
Mm-hmm.
N1B, it is a clinically palpated node.
Okay.
N1C, no nodes are there, but there is a satellite metastasis or there is a in transit nodules are
Okay.
present.
Okay. Very good. What is N2?
Similarly, in N2, instead of 1, there will be 2 or 3 clinically occult
Okay.
nodes. And N2B again 2 or 3 clinically palpated
Very
nodes.
good. Very good.
N2C whether it is one clinically or a palpated node, but there will
Very
be
good.
in transit or satellite metastasis.
Fantastic. What is the N3?
N3 again, N3A it will be 4 or more clinically occult nodes. N3B will be 4 or more clinically palpated nodes.
Mm-hmm.
And N3C again, the C will be having 2 or more clinically detected or occult nodes with in transit or a satellite metastasis.
The other thing point you have to tell is matting of nodes, clumping of more than 2 nodes. That also comes under N3C.
Okay,
All
sir.
right. Very good. So that completes that part of it. So how do you want to work this patient up?
So for management, first I'll investigate the patient.
Mhm.
I'll do investigations for the general assessment of
You
the
go to
patient.
the specific investigation. What is the one approved tumor marker for the melanoma?
So it is HMB 45.
No, go back. Tumor marker. These are all immunohistochemical markers. Tumor marker, what we call is serum.
Okay, sir.
You had
LDH
listed in
for
your PowerPoint. Ah, yes, very good.
L.
So
Okay,
LDH is the important blood marker.
okay,
Then
sir.
comes your immunohistochemical markers. But before that, we will go one by one. So how do you want to work this patient specifically?
Specifically, first investigations to confirm the diagnosis. I'll do a excision biopsy and
What are the types of biopsies you know?
so excision biopsy, incisional biopsy,
Hmm.
wedge biopsy,
Hmm.
uh, edge biopsy,
Hmm.
edge wedge biopsy, sir.
You are getting into trouble now. Don't worry, don't worry. Go ahead, go ahead. See, the point is, are you giving a curative excisional biopsy or a diagnostic biopsy? Right. If you are doing a total biopsy, it should be a full thickness excision biopsy. That is what you are expected to tell. When you talk about excision, you cannot be leaving out some tissues. See, when do you do excision biopsy? When do you do incision biopsy?
So incisional biopsy will be doing when there is a very large lesion, especially in the cosmetically important areas like in the face, neck, near the
That is
eyes.
one viewpoint of it. If you are planning for or your clinical staging is 1 or 2, or where you feel a one-time single stage excision can be curative from the T point of view, then that is called excision biopsy. Anything
Okay.
short of it, right, can be called, if the lesion is very big, you can do a punch biopsy. The lesion you want to assess the clear thickness. What is the edge biopsy or a wedge biopsy? How do you do an edge biopsy?
So edge biopsy will be taking the tissue from the edge of the lesion, sir, which will be
Which
having
will also include,
the normal tissue, sir.
which should
The
have a chunk of normal as well as the involved tissue.
involved
So
tissue.
a wedge, broader wedge should be on the tumor side, narrower wedge should be on the normal side. So the most important thing is how thick your biopsy should be.
So we should take the involved lesion along with the subdermal fatty tissue.
Minimum of 2 to 3 millimeter more, because that's how your T status can be clearly made out. Then, if you're doing what is incision biopsy?
So incisional biopsy will be taking only some part of the tissue or the involved lesion will be
A
taken, sir.
segment of tissue alone is taken. Again, full thickness with nearby normal tissue.
Hard,
Minimum of 3 millimeter of normal tissue.
hard.
Very good. So, having done a biopsy, um, now we'll limit first only to the local tissue. So what are the study you would like to do with the excision biopsy tissue?
So we'll send it for histopathological examination for seeing the thickness of
Okay.
the involved tissue, sir. The
Okay. So
depth.
in your patient, we will talk. So you have a 4 centimeter lesion. So you have removed the entire lesion in one go with full thickness. With your naked eye, you are not able to see any residual tissue. You gave adequate margin. So with that, you have marked a label to the pathology department. Here whether I'm sending so and so. Kindly do a histopathological examination. What are the information you are looking at from the pathologist?
So we'll look for the Breslow thickness,
Okay.
and then we'll group it
What is
according.
What is Breslow and what is Clark's?
So in Breslow thickness, we'll be seeing the depth of invasion in millimeters. We'll be giving it, sir,
Very
with
good.
the
So how do you
measurement.
categorize thin, thick, and very thick?
So thin, it will be less than 1 millimeter.
Mhm.
1 to 4 millimeter, we'll be giving it in the intermediate. More than 4 millimeter, we'll be giving it thick, and
Okay.
based on that, we'll be deciding the prognosis of
So
the
the
patient.
examiner asks you, you should be also prepared to state about 0.75. Some examiners still
Yes,
descend
sir.
on that. They can go
First,
0.76 and above and 4 and above, that's fine. But what you say is perfectly fine. If you can tell 1 millimeter as a limiting factor, it is perfectly fine. And you have variable thickness lesions. You have to take the maximal thickness and whichever point should be the taken as the T status. All right.
okay, yes, sir.
So that is about the measurement part of it. Then what are the other information from the pathologist you are looking at it?
So then the Clark's level, we'll be seeing how much the tumor has invaded into the tissue.
Mhm,
Accordingly,
mhm.
we'll be giving 5 levels, sir. Where the first
Okay.
level, it will be limited to the epidermis. In
Mhm,
the second level, it will enter into the papillary dermis.
mhm,
Third level, it will be extending fully into the papillary dermis up to
mhm,
the junction between the papillary and reticular dermis. In
mhm,
four, it will extend into the reticular dermis, and in
mhm.
level 5, it will extend completely into the subcutaneous areas.
Fantastic. But then now by and large, the Clarks have been replaced and Breslows
Uh,
and associated. What are the associated pathological finding you will be looking at? You
so
told about the confirmation of the subtype of melanoma. What is the thickness? Then what other information you were keen in planning the therapy for this patient?
so if,
Associated.
so, the surrounding
Hmm,
intransit
hmm.
nodules and the
No,
satellite
before
metastasis.
that is the desmoplasia. So peritumoral desmoplastic creation. You told in the clinical part, no, you told about the induration. So induration is the what in pathological word is the desmoplastic reaction which happens around the tumor. In other words, I would expect you in when you're writing your theory to talk about the tumor infiltrating lymphocytes and the peritumoral fibrosis and desmoplastic reactions are the next important information for you to prognosticate these patients. All right. Then if you have a doubt, right, if you have a doubt, what are the potential doubtful melanoma subtypes,
So there will be amelanotic melanoma.
Very
Not
good.
in this case, like
Now leave alone this patient. I'm asking for an exam purpose. If somebody is going to ask you, see, you have some doubtful lesions which may or may not be melanoma. If you are asked to list out the doubtful lesions, what are the things you would tell?
so first amelanotic melanoma, because it
Mm-hmm,
will not be pigmented, because the
mm-hmm,
tumor cells they'll completely lose their identity. They will be
mm-hmm.
undifferentiated fully, so they will
Okay,
appear as a fleshy pinkish lesion.
okay.
And there is another uh, desmoplastic type of melanoma, and
Mm-hmm,
it is a very aggressive type because it
mm-hmm.
will also have a perineural infiltration.
Otherwise called neurotropism. That is what I wanted to ask. Listen from you. Okay, go ahead.
Okay, sir. And subungual type of melanoma, uh,
Mhm.
it will be occurring below the nail.
Okay, I
And
think we are losing concentration and going towards the subungual. But the answer what I expected from you is the first 2 points are perfectly okay. So the other things are atypical melanocytic proliferation. Then sometimes we call something as an atypical melanocytic tumor of uncertain potential. Then superficial melanocytic tumor. Then atypical Spitz tumor and atypical cellular blue nevus. These are the things what are expected in atypical things. Because these are all potential MCQ questions also. So you should be aware atypical melanocytic proliferation, melanocytic tumor of uncertain malignant potential, superficial melanocytic tumor, atypical Spitz tumor, and atypical cellular blue nevus. All right. So keep
Okay,
this
sir.
in mind. If and if your diagnosis is uncertain, when you have a certain diagnosis, then you need not worry about it. Okay. Then when do you depend on you? I could see you had a slide on immunohistochemical markers. When do you want to do immunohistochemistry?
So, like when we are not able to
So
confirm the
indeterminate lesions. So
Okay.
what is S100 signifies? S100, does it diagnosis of melanoma or it excludes melanoma?
So S100 it will be for the catecholamine producing.
In other words, it excludes smooth cell origin of malignancy. Then what
Okay.
is HMB45 melanoma? If your
Human
if
melanoma.
whatever the atypical list of tumors which I said, the atypical melanocytes of undifferentiated potential or Spitz tumor, all those things, then comes your the HMB45 melanoma, where presence of this is more towards diagnostic of a potential melanoma, where a conventional is eosilin and hematoxylin does not give you the clarity of the information. All right.
Okay.
And then
Okay.
there are some centers, especially when they have an element of doubt, and if they are planning for a neoadjuvant therapy, then these type of tumor markers are important to assess the status of the response of the disease to your neoadjuvant therapy. Let us now
Okay.
wait for therapy part of it. Now, these are the potential immunohistochemical markers rather than tumor markers. Tumor markers is what you see in blood. All right. Otherwise, you
Okay.
mentioned are immune markers. That's the right word. Go ahead. Go to the next slide.
So the treatment part
Hmm.
for the primary tumor, Hanley's wide local excision and clearance of the margin and the depth and covering the lesion with a primary split skin graft after excision, and for lymph node secondaries, ilioinguinal block dissection.
Can it be a little better way? You are doing good in a little better way. See, ilioinguinal block dissection is too morbid procedure for your patient, right? You said only one node, right? Am I right?
Yes, sir. Yes.
One significant node, that too on the vertical chain. Do you think a ilioinguinal block dissection will be a indicated procedure, or can it be a much? Do you want to do something in between?
So radiotherapy.
Mhm.
So
We
we
are
can
not
give
going
a
to that.
isolated limb perfusion.
They're all much later. Before that, apart from that, do you do any specific? You see, whatever we are trying to deal is a T lesion is there. We have N lesion clinically. That is CT positive, N positive, M indeterminate. That's what we are dealing with in your patient. So N is, according to you, what N it is this?
N1B,
You
sir.
said you don't have in transit, you don't have satellites,
That.
you don't have any other evidence of tumor budding or anything. Let us not worry about it. So you do not have satellites or you do not have in transit metastasis. So you do not have any other skin changes along the path of the tumor spread or tumor lymphatics. So you still want to do a ilioinguinal block dissection, or you want to do something before that?
Uh,
Can they
lymphatic
inject something around the tumor to look
Yes, sir.
for?
You can go for a sentinel node biopsy.
See, whenever you see only one node or anything, see if you have a group of nodes. If you have a group of nodes in the inguinal, if you have a group of nodes in the paraortic or external iliac, then no point of talking about sentinel node. But if you have a clinically negative node radiologically picked up, or a clinical and radiological negative node with doubtful induration, then you do a sentinel lymph node. How do you can you explain me what is the SLNP concept in melanoma?
So sentinel lymph node, it is the first node which will be receiving the tumor cells from the primary tumor in the
Okay,
regional lymphatic basin.
okay.
So if the sentinel lymph node is not involved, so we can be assured that the tumor has not spread.
So
It
what are
has
the
not.
techniques of sentinel lymph node biopsy, sentinel lymph node, SLNB?
So we'll injecting a blue dye, which is isosulfan dye,
Very
and
good.
along with
Where
that,
do you inject?
so we'll inject intradermally in the around in the area surrounding the tumor, or in the
Ideally,
margin.
along the potential
Margin.
lymphatics towards the regional nodal basin.
Okay, sir.
That is the right word to tell. The technique of SLNB is a procedure where you inject a contrast or a dye,
Technician.
which is usually done just adjacent. There are two techniques. One is intralesional injection. The next is perilesional injection. So the perilesional injection is optimally done. See, for instance, if you are talking in your patient, see the upper part is the ideal one, where that's how the lymphatics take off towards your groin nodes. So no
Yes,
point
sir.
in injecting somewhere around the heel region, which is well away.
Mm,
All right,
yes,
that is one. So along the track of the lymphatics will be the SLN injection. Okay. Can we
okay.
do something like a patient is telling, Madam, you are going to do one local excision and a skin grafting. That itself, I'm worried. If you're doing for an ilioinguinal block dissection, I feel it's a very big procedure. Can we avoid ilioinguinal block dissection, or if you can tell us preoperatively, we'll be happy. Any other thing along with this, whatever so far we discussed, will be of much use for you?
So apart from the sentinel node biopsy, sir.
Hmm. Hmm.
So lymphoscintigraphy.
Very good. How do you do lymphoscintigraphy?
So in that we'll be giving technetium 99 and.
Where do you give technetium, madam?
Mm. So
So
that
usually in the
also
web
is
space, usually in
web.
the first and second web space. So that gives a clue because the idea here is to opacify the lymphatics. So optimally given in the first and second web space between the first toe and the second toe, or the second toe and third toe, you inject in the web space, go into the deep into the web space. From there, the lymphatics take over. Your technetium 99 ascends towards the regional node. So that is
Mm.
the, so otherwise we simple words you tell. After injecting the technetium, I do a lymphoscintigraphy where I will be able to pick up hot spots. Hot spots is you have, depending on the type of method, you do a color scintigraphy or a normal scintigraphy. If you are using a white and black method, you will see a black aggregation of the contrast in the area of the potential lymph nodes. If you're doing a color scintigraphy, you can have hot spots, which usually enhances from yellow to red color, right? So depending
Okay.
on what type of methodology you use, it can be, in other words, you can tell the presence of hot spots in the tumor and the presence of hot spots in the drainage basin gives a preoperative assessment. Then as
Okay.
well, the other thing what you can preoperatively assess is a image guided nodal assessment. Image guided nodal assessment can be a regional superficial ultrasound or a drainage zone ultrasound. Usually superficial ultrasound is called a high frequency ultrasound where probes above a range of 20 kilohertz are used for assessment. When you use in the abdomen, you use somewhere between 2 to 10 kilohertz of the probes where it is well deeper from the skin. If you want to use a superficial assessment, you do a high frequency ultrasound probe to assess the nodal status. If
Okay.
in case your ultrasound, see, do you have any radiological categorization of differentiating a node from benign to malignant?
For malignant melanoma, sir.
In general first, then malignant melanoma specific.
So we'll have the for with respect to the ultrasound.
Yes, ultrasound or CT imaging wise.
So we'll be giving BIRADS, TIRADS.
No, that is different. That is for your breast and thyroid. Let us not jump into it. See, very simple thing. What as I expected from you is to assess the size of the lymph gland. Any lymph gland more than 1 centimeter.
Oh, okay.
Usually, lymph nodes are ovoid or it has long axis and short axis. So when the lymph nodes become rounded or it becomes globular, it becomes a high risk of malignancy. And then status of the nucleus or the central core of the lymph node. So usually the lymph tumor cells can become in two ways. Can be a cystic degeneration of the lymph node, or it can be a replacement of the hilum of the node with tumor tissue, where usually you have a lymph node has a hilum, which is the central core, which is usually radiolucent, and then you have the cortex of the lymph node, which is little bit hyper intense in the normal node. But when tumor replaces, in melanoma, if it replaces, the entire lymphatic architecture is lost. So there is no differentiation between hilum and cortex. And then it also breaches the lymphatic capsule. And then if there is total destruction of the lymphatic tissue, there will not be a barrier of normal radiolucency between two lymph glands, where you can see breach of the capsule, extra lymphatic spread of tumor tissues, and then in more advanced situation, tumor encroachment into the nearby nodes or nearby neurovascular structures. These are the things what you are worried about. All right. So this very typically escalates the M status or N status also. All right. And then when you are talking about ulceration of the lymph glands also is important regionally. All right. These are the important things one should be aware of or one should be looking at after doing an imaging study. But then if ultrasound is indeterminate, your ultrasound is not very categorically telling, or there is a suspicion of the element presence of node, but what are the parameters which I said now may or may not be present, then you need some more specific tests to identify whether it is benign or malignant by form of imaging. A normal next escalatable test is a CT scan. And then if CT is also indeterminate, we can do metabolic imaging. What is metabolic imaging?
So PET scan.
So fluorodeoxyglucose, right, or the metabolic imaging. What is the principle of metabolic imaging?
The cancer cells, they will be utilizing, like, they'll be utilizing the, I forgot, sir.
So don't worry, it increases or it implies any tumor tissues have a higher turnover of metabolism. So when there is higher metabolism, they consume more glucose than a non-tumorous tissue. So the circulating body glucose is tagged with fluorodeoxyglucose. So the fluorodeoxyglucose gets accumulated more in a tumor cell or a tumor lymph node or a metastatic zone. That is how the fluorodeoxy. So how do you say whether whether the tumor is metabolically active or not? Is there any way to measure, like how you measure sugar? You measure sugar as so many milligrams per deciliter. How do you assess metabolic imaging?
So the color, the 3D colors.
Better way to tell? It is called SUV, otherwise called the standard uptake value. All right. So standard uptake value is the computer measured radian. When it is +5, it is suspicious of malignancy. +7.5, you usually tell it is more certain of malignancy. All right. And then now you have more specific imaging depending on what type of tumor, what you're dealing with. Apart, fluorodeoxyglucose is general. But again, how do you use tumor markers? The PET scan also becomes specific. Say, for instance, if you are dealing with the neuroendocrine tumor, you can use DOTA. If you are using specific tumors like insulinomas or somatostatomas, you can go for specific receptor-based PET-CT also. But these things are for your MCQs, not for your exam. So in your case, if you have an element of doubt in ultrasound, a clinical element of presence of nodal, then you escalate to ultrasound. Ultrasound is doubtful, then you go to the CT. CT is doubtful, then you go for the FTG. The only condition where you want to do an MRI in melanoma patient, where do you want to use MRI?
So if you're suspecting brain metastasis.
Fantastic, fantastic. So if you are suspecting choroidal or leptomeningeal or cranial metastasis, then you go for MRI. All other things you do with ultrasound or CT is more than sufficient. You may not need an FDG PET. unless you are suspicious of something in the CT and ultrasound. Okay, fantastic. So that part, imaging part is completed. So based on that, what will be your out? Do you have the pathology report of this patient?
No, sir.
Okay.
Like,
What do you think will be the potential pathology report? See, I would say in this patient, if you are going to tell, I would like to give a wide, full thickness, three-dimensional excision of the tumor with clear circumferential, that is, I would say radial and vertical margins. So how much of clearance you give for this patient?
so for like
How much
depending
of
upon the,
normal skin you remove along the tumor?
so for more than 2 millimeter, we'll give 2 centimeter margin clearance, sir.
Very good. Very good.
If it is less than 1 millimeter depth, in that cases we can give 1 centimeter margin.
Correct.
And in
So, go ahead.
for in situ melanoma, we should give at least 0.5 millimeter margin clearance.
Fantastic. So you generally tell in your patient, if you're going to give a 2 centimeter circumferential or radial clearance, that should be fine. And it should be a minimum of 3 millimeter depth clearance if you're doing a depth excision. But the challenge in your patient is giving 3 millimeter depth clearance, because around the medial malleolar region, you may not have that three-dimensional clearance. You may end up handling the tendon, or you may end up handling the blood vessels or the neural bundles if you are going to give a 3 millimeter clearance. So you tell structurally and macroscopically clear margins are the one which are aimed at. Generally, unless there is deep ulceration or there are associated complications of the lesion, what you're talking about, no point in sacrificing tendons and nerves for these things. If it is blood vessel alone isolated involvement, if you have the dorsalis pedis, then you can sacrifice the posterior tibial. That's what is expected to run along with the inner area. So if the other vessels are good, you can ligate the blood vessels. But then there is no point in removing the posterior tibial nerve or the common peroneal, depending on what your patient has. And generally, we don't remove a structural or a neurovascular structure unless there is direct infiltration of the tumor into the specifics. All right. So is there any investigation? So we talked about investigation for nodes, investigation for metastasis. Is there any investigation which can be used for T status?
So the biopsy which we are taking,
It
like
is only the excision biopsy which is going to help us, because in less than 1 centimeter lesion, none of the investigation CT or MRI are very sensitive in identifying. So it is more of a procedure in the sense excision or incision based procedures, which is going to help us the ascertain the T status. All right. So this is about T, N, and M. So you tell I would give a 2 centimeter clearance, minimum of 3 centimeter depth clearance, macroscopically and microscopically clear margins, and then I will be doing a sentinel lymph node assessment, depending on whether the sentinel lymph node is lighting up or not. If it is lighting up, then I will do a regional lymph node dissection. So regional in the sense you do a one station above the normalcy. Usually you limit to infrainguinal block dissection. That is sufficient in your patient if the patient has the lowermost chain T positivity. If the patient has the horizontal chain positivity, then you also have to dissect the suprainguinal block dissection. All right. And then when your CT tells if they have obturator node positivity, then you also do a pelvic block dissection also, or then comes your ilioinguinal block dissection. So ilioinguinal for only one node is too morbid a procedure. You tell I would do a regional nodal dissection or a selective infrainguinal dissection. That is sufficient. But then as you dissect, when you dissect, there are associated features of neurotropism, or vascular involvement or extra capsular spread of the tumor from the node what you dissect, then you go for one station above. All right, that is what you are expected to tell. And then what is the information you expect out of the nodes dissected? The pathologists have to tell some information after the nodal dissections, what you have done. What is that you want to expect from them?
So, like, the, like how the nodes are, the size, and if
See, the point is the first thing is how many nodes are removed totally. All right. Say, imagine you have removed 10 nodes, 20 nodes, or 30 nodes. The first information is how many nodes are removed. The second information is of the number of nodes removed, how many nodes are positive for tumor deposits. All right. Then, if there are tumor deposits, how much of the what meant some virus you are sending? Okay, don't worry. So, of the lymph node pathologically involved, you tell the amount of disease which is replacing the lymph node. Lymph node architecture is preserved, lymph node architecture is deranged. Is there any residual lymph node at all, or the entire lymph node is replaced by tumor tissue? And what all I clinically said, you have radiologically we discussed, right? So if you have a capsular breach, if you have a extra lymph nodal spread, if you have contiguous infiltration into nearby nodes, loss of architecture, or if you have direct incontiguous infiltration into neurovascular bundle or nearby structures. So all these things your pathologist will be able to say. Fine. Now, assuming you have removed, you are a good surgeon, you have removed 25 nodes, that is almost cleared the entire infrainguinal nodal tissue. You patient, the pathologist says, madam, your tumor is negative of, like it does not have any positive cells in the resection margins. All these vertical and radial margins are clear. But unfortunately, in the lymph nodes dissected, 12 of 25 nodes have turned positive for tumor deposits. What do you want to do? What other information you want to expect from the pathologist? Okay, I will tell you the answer. So if and if you want to tell, you have to ask them the farthest node from the first node you removed, whether it is positive or negative, or the peripheral nodes, most peripheral node. In your case, that is why you have to mark which is the first node. Usually you do with one stitch and send. So the pathologist will identify, okay, this is the first positive node. So they will have, you will have to mark which is the medial bunch of the lymph node dissected, lateral end of the lymph node dissected, and the most superior end of the lymph node. Generally, that's why we don't do a piecemeal dissection. We do a incontiguous dissection as a single bunch of tissue along with the soft tissue, fat, and loose areolar tissue. So the pathologist will be able to tell, madam, whatever you have dissected, the lowermost or the clinically positive nodes alone have tumor tissue. The uppermost, the close to the inguinal ligament part of it are free of tumor. Then you are happy. If the pathologist is going to tell, madam, lowermost is also positive, uppermost is also positive, then obviously means we have not surgically cleared the disease. So what will be expected to do? There are two ways to do it. One is if your scan is telling or repeat scan is telling, yes, you have left with multiple para-aortic disease or you have left with the external glands. If it is a surgically removable thing, patient may require one more surgery to remove the nodal metastasis. But then if you have para-aortic or celiac axis metastasis or celiac axis lymph nodes, no point in removing the entire lymph nodes. Then comes the question of irradiation. So irradiation can be done for high risk tumors. What are the potential high risk tumors or tumor which has poor prognosis in melanoma?
the nodular type and
Very
the
good.
acral lentiginous type,
Yes.
desmoplastic melanoma.
Yes.
Uh,
Then presence of ulceration, presence of bleeding, Ulceration of a local, ulceration of the lymphatic area, what you're dealing. These are all poor prognostic factors. And then very high LDH levels and persistently high LDH levels even after doing the primary and nodal dissection. When your LDH level, you normally expect within 1 week to 2 weeks LDH levels to resume to normalcy. But then if LDH levels are persistently high, even after the clearance of the primary and nodal tissue, then you are worried. Then you have to identify and seek for any residual tumors which are left behind. Patient is telling, Madam, I don't want one more operation. You do something which is non-operative. I've had my surgery enough. I don't want any more operation. So what can be done for these patients?
The radiotherapy.
So you can do a external beam radiation therapy. But if the patient is having supraclavicular node, if the patient is having hilar node, if the patient having mediastinal nodes, what can be done? So you go for some form of adjuvant therapy. So how do you plan adjuvant therapy in these patients? What is the most common schedule or most common regimen adjuvant therapies are used for?
The CVD regimen.
Very good, very good. What is CVD?
So with cisplatin, vincristine, and dacarbazine will be
Very
given,
good,
sir.
very good. So isolated dacarbazine also being tried. Depending on your institutional protocol, you can use for isolated dacarbazine or use a CVD regimen. Patient is telling, Madam, I don't want chemotherapy. Chemotherapy is very, I will become very sick. I will lose my hair. I will lose my eyelashes. I will not be able to take. I will be vomiting. Give something which is not going to trouble much. So what are the other options we have?
So we can give a targeted therapy.
Fantastic. So that is where you said some tests to be done, no, along with that regular pathology. What are the markers you wanted to do?
So HMB 45
That is
melanoma.
the immunohistochemistry. For targeted therapy, you should be able to assess the mutation, no? Then only you'll be able to assess. BRAF mutation and KIT mutation are the most important. So very good. So what are the MABs you want to use in these patients?
So against the
Sorry.
against the BRAF, we can use dabrafenib. Then for the MAP kinase pathway, we'll be having the tremitinib, and then ipilimumab. And
very good, very good. So in very simple way, in exam point of view, you tell there are 3 type of targeted therapies. One is the immune checkpoint inhibitors. The second is BRAF targeted therapies, and then a combination therapy. So a very simple example for immune checkpoint inhibitors are ipilimumab and nivolumab, and pembrolizumab can also be tried. Whereas in BRAF targeted therapy, the dabrafenib and vemurafenib are the most important drugs which can be. So there can be a combination of immune checkpoint inhibitors, or there can be a combination of immune checkpoint inhibitors and BRAF targeted therapies can also be attempted. All right. And then I would be interested in knowing, how do you deal brain metastasis?
So for brain metastasis, we have to think of giving radiotherapy.
Yes. So it can be a focused, specific. Do you have any idea about what is cyber knife?
Yes, the cyber knife and gamma knife is also there.
What is gamma knife? What is cyber knife? Okay, you go and read. Let us not make more complex things. We'll make things much easier for you. I would like to close with few important questions to you. What is a microsatellite? You told about the satellite lesion, right? What is a microsatellite?
So microsatellite lesions, it will be occurring within 2 centimeters from the primary tumor, sir.
Okay. Minimum size of?
Size of?
Usually microsatellites are pathological diagnosis. It's very difficult to clinically make out. So microsatellite can be anything more than 0.05 millimeter in diameter. Where all microsatellites can be located? It can be located in the reticular dermis It can be located in the fat or the panicles, or it can be in the microvasculature beneath the principal invasive tumor. The most important thing is it should be separated from it by at least 0.3 millimeter of normal tissue. All right, that is one. And then you have to, what is in transit metastasis?
So in transit metastasis, it will be more than 2 centimeter from the
Away
primary
to
tumor.
more than 2 centimeter away. Very good.
And in between the area between the primary tumor and the regional lymph nodes, in the lymphatic
Fantastic.
pathway, it will be present.
Very good. So if and if you are going to do a incisional biopsy or a wedge biopsy, especially not doing an excisional biopsy, it should be along the channel or in parallel to the lymphatics of the primary tissue. This you should keep in mind whenever you are planning for an incisional biopsy. All right.
Okay, sir.
So I think we have covered most of the things. Um, what is the survival after in your patients? Is the patient is having good prognosis?
So the patient, if the patient is not having distant metastasis,
No,
if
in your case, it is local disease, all margins negative, ilioinguinal block dissection, only 2 of 20 nodes positive. What is that you want to do?
so then it will be mostly coming in the stage 1.
Correct.
And so the prognosis, it will be a 5-year survival rate will be around 90%.
Fantastic, fantastic. So how do you want to follow up your patient?
So like my patient is in the stage 1, so I'll follow him up every 6 months for the next 3 years.
Okay,
And during that time, we can do the LDH, serum LDH levels. We
very
can
good.
assay we can do, and
So
we
alert the patient to report if there is any local occurrence of pigmentation, or in this patient should be allowed, or patient attenders should be educated to look for any new occurrence of moles, or if they have existing moles which do change in size or variegation or ulceration or any change happen, they should bring to your notice immediately. All
okay.
right. And then preferably wear sunscreen if and if they are exposed to, again, as you rightly said, in your patient, he has chronic exposure to sun.
Yes.
All right. So that covers reasonably most of the things. But in general, melanomas are kept as a spotter. Most of the time, they will have ulceration and nodular disease. So very simple way to sum up, stage 1 and 2 will be surgical option directly. Stage 3 can be surgical plus nodal dissection dealing with the nodes. Stage 4 will be essentially neoadjuvant therapy, control the disease, and then cytoreduct or control the local thing for a palliative purpose. Because generally, stage 4 disease, the survival is 10 to 15% in 5 years. We don't have longer survivors beyond 10 to 15%. But then, if they have a BRAF positive and they are good responders to your BRAF therapy, MAPS, then they have a better survival. The single limb perfusion, you said about it. So how do you do that single limb perfusion?
So isolated limb perfusion. So we'll cannulate the femoral vessel, the
Very
femoral
good.
artery, and the femoral vein,
Very good.
and then
So
the
it is exclusion of the vasculature of the limb, involved limb.
Yes,
Then
sir.
you use what type of chemotherapeutic agent you want to use?
So for melanoma, we use melphalan,
Fantastic.
and so the venous blood is taken. It is oxygenated. It is mixed with the chemotherapeutic agent. It is
Correct.
sent to the limb, and
Correct.
then when it comes out, it is again oxygenated and sent back into the body. So it
Fantastic.
avoids the systemic toxicity of the drug.
Fantastic. Very good. So I think Saloni, you have read very well. You did well. Any more slides you have left with for discussion?
No, sir. This much
Okay.
from
Do you have any questions to me?
Mm.
Anyone having questions?
Sir, regarding that the biopsy only, sir.
What is the
Like
doubt?
so, like in some books they'll be saying do incisional biopsy only when it is a very large lesion, and some say when it is in the cosmetic area. So, like So what
See,
we
the
should
point is like this, Kana. So if generally cosmetic or non-cosmetic is secondary,
okay.
primary, the disease load drives you the type of biopsy what you're going to do. Assuming if you can give a skin cover can be split skin graft or a full thickness myocutaneous flap, or assuming you have a 4 centimeter lesion, you are going to knock off 1 or 2 centimeters all around. So it should be 6 centimeters defect.
Yes, sir.
So 6 centimeters defect across, if you are able to rotate a specific flap, depends on where you are dealing with. Face for a 6 centimeter lesion will be very challenging. Then that is where if you have a 1 centimeter lesion in the face also, the first preference will be to excise altogether. If you have a 5 centimeter lesion in your leg, calf region, or somewhere in the dorsum, then you can always rotate, because in calf region, when you go there, your gastrocnemius flaps, you have multiple flaps, and they are much pardoning areas.
Yes.
In acral, that is the palms, soles, nail beds, that is where the real challenge comes. In nail beds, aggressive nail bed tumors, ulcerated tumors, sometimes they even use a disarticulation as a one way of handling it. So in general, if the lesion cannot be primarily covered, when you're doing an excision, when you've done a total excision, you don't have the expertise to cover, or you cannot mobilize the flap, skin flap, either a split thickness or a full thickness or vascularized flap, then you do an incisional biopsy.
Okay.
If you have a big lesion, adequate thickness, like adequately big lesion, ideally you give 1 centimeter lesion, 1 centimeter biopsy with the full thickness or beyond the depth normal tissue, that gives the pathologist adequate information. But then your variegated types, your boundaries are not clear, the halo is unclear or uncircumcised halos, then you do an extended wedge. So the wedge should involve tumor, doubtful induration or the halo area plus normal area. That is where your pathologist will be able to clearly tell. But then an alternative option will be to do a full thickness punch biopsy, right? There are punch biopsy for equipments which are available, which make 3 millimeter, 4 millimeter cores, right? It drills, or takes the core of the full thickness using a punch, and the entire full cylinder of tissue is sent to the pathologist. You don't even need to suture the biopsy area. You just apply a dressing, it heals off. That is as simple. So punch biopsy is taking up in a big way. And SLN also, now people tell, you do an ultrasound. If you see a ultrasound positive node or a palpable node, you do a ultrasound guided fine needle aspiration from the node. If the node is positive, then no point in doing SLN. Then you have to go for a definitive block dissection also. All right. So biopsy from the T, biopsy from the N are little different. In melanoma, if you are trying to give a cure, give cure. Even in metastatic melanomas, say assuming you have cranial metastasis, or if you have lung metastasis, if you feel the primary can be fully removed, you remove it as an excision biopsy. Ideal information should come from the primary to ascertain the subtype of the melanoma, and it also gives information if you are going for a targeted therapy. If you the other information like BRAF or KIT or other markers can be studied in the lymph gland also. So if you get to do a huge mediastinal node, somebody is not looked upon, generally most of the time what happens is the primary is occult. Patient may be having in covered areas. So then you end up doing a biopsy from the secondary deposit. There they suspect a melanoma and come to the primary. There also you do a full thickness excision biopsy.
Okay, sir.
All right. So you got confused. Don't worry. Today what you do is you go to a website called NCCN. All right. National Cancer Control Network. It is the American Cancer Control Network. You have tumor-based management protocol. Whenever you have time in between time, you can go through. That gives a very crisp approach to how to handle these patients.
Okay, sir.
All right. Any other questions
No, sir.
from anyone else? I think all of them have already left the group. They are bored of the class, I think. Okay, don't worry, Saloni, you did well. All the very best to you.
Thank you so much.
So I think we have reached 5 o'clock. The next class should be beginning shortly. Vasant, anything else, Vasant? I think Vasant is not there. Thank you,
Sir,
students. Hello.
Hello, sir.
Yes, Vasant.
Yes, sir. Juniors having classes at 5.
Okay. So I will take leave. Thank you, students.
Thank you
Look
so much, sir.
forward to listening from you sometime later. Bye-bye.
Thank you,
you,
sir.
All the very best, Saloni, and all the students who have stayed with till the end. Bye-bye.
Thank you,
Thank
sir. Bye, sir.